This presentation provides a rationale for a new classification of obstetrical disorders based on the combination of symptoms and signs as well as the results of placental pathology. We begin with a simple question: why a new classification or taxonomy of obstetrical disease? The maternal mortality rate has decreased over the last 100 years. This has been attributed to the introduction of prenatal and interpartum care. Specifically, the advances in the treatment of hemorrhage, infection, and eclampsia have improved maternal outlook. The same is true about infant mortality with the introduction of newborn intensive care units. Yet, most complications of pregnancy remain difficult to prevent, and the only treatment for some is delivery. Why? The most likely reason is an incomplete understanding of the causes of obstetrical disorders, since treatment requires knowledge of the causes of disease. The current classification or taxonomy of obstetrical disease merely describes the symptoms or signs of patients. For instance, we use the term preterm labor to describe a patient who presents with contractions regardless of whether this is due to infection or uterine overdistension. We refer to fetal death as a single entity regardless of whether the cause is an umbilical cord accident or a placental abruption. The name of other obstetrical disorders also describes symptoms. This taxonomy of disease has resulted in misguided treatment. For example, the attempts to stop uterine contractions with tocolysis is predicated on the belief that the contractions are the problem rather than the manifestation of an underlying pathological process such as intra-amniotic infection or uterine overdistension. We propose that the classification of obstetrical disease exclusively based on symptoms and signs has been an obstacle for progress in obstetrics, and argue that an alternative approach for prediction and prevention should be based on the understanding of causes and mechanisms of disease. The overarching goal of this line of research is to propose a new classification of obstetrical disease informed by its causes. We believe that this is possible by bringing the knowledge of anatomical pathology to obstetrics. The placenta is the largest human biopsy, universally available and considered a diary of intrauterine life. The placenta is essentially a vascular organ. Maternal blood traveling in the spiral arteries enters the intervillous space and brings nutrients and oxygen to the fetus. Abnormalities of maternal vascular malperfusion can impair perfusion, lead to microscopic placental infarctions, which can become gross lesions. Maternal vascular lesions of malperfusion are common and can be observed in several obstetrical disorders. Until recently, it was not possible to identify the mother with these lesions before delivery. The ratio of PLGF soluble fleet in maternal blood has emerged as the first biomarker for maternal vascular lesions of malperfusion. A low ratio in the mid-trimester predicts the patient who delivers before 34 weeks a placenta with maternal vascular lesions with a high likelihood ratio equal to 23. Placental growth factor and soluble fleet predict maternal vascular lesions of malperfusion, and indeed, these analytes predict preeclampsia and fetal death, as these conditions have a high frequency of placental vascular lesions of malperfusion. This study was conducted to determine if the maternal plasma concentrations of PLGF and soluble fleet differ according to the presence or absence of maternal vascular lesions of malperfusion in patients with obstetrical syndromes. To address these questions, we compare the trajectory of maternal plasma concentrations of PLGF and soluble fleet among study groups based on data collected in a longitudinal retrospective case cohort study. Cases include patients with preeclampsia, small for gestational age, preterm labor, and preterm prom, as well as controls. Biomarkers were measured with sensitive and specific immunoassays. All placentas underwent pathologic examinations by pathologists blinded to the clinical and obstetrical outcome. We first determined the longitudinal trajectories of the biomarkers in patients with normal pregnancies. The first important result was that biomarkers PLGF and soluble fleet became informative earlier in gestation when obstetrical syndromes were defined according to the presence or absence of placental lesions rather than clinical description alone. We will illustrate these findings first for preterm labor and delivery with intact membranes. In this graph, the white line represents the profile of placental growth factor as a function of gestational age in normal pregnancy. The blue line is the profile of patients with preterm labor and intact membranes. All patients are included regardless of placental pathology. The difference between the two lines becomes significant at 32 weeks. Among patients with preterm labor, the profile of placental growth factor is different in those with placental vascular lesions of maternal malperfusion, shown in red, and in those without lesions, shown in yellow. If placental pathology is not considered, the difference in the PLGF profile between patients with preterm labor delivery and normal pregnancy becomes significant at 32 weeks. In contrast, a significant difference is detected at 27.5 weeks if there is evidence of maternal vascular lesions of malperfusion in the placenta. In patients with PROM, the profile of PLGF becomes different at 29.5 weeks of gestation, but as early as 26 weeks in the presence of lesions of maternal vascular malperfusion. Similar findings were found also for small for gestational age neonates. If placental pathology is not considered, the difference in the PLGF profile between patients with SGA and normal pregnancy becomes significant at 20 weeks. In contrast, a significant difference is detected at 17.5 weeks if there is evidence of maternal vascular lesions of malperfusion in the placenta. Finally, in patients with preeclampsia, differences between all cases and controls emerged at 17 weeks of gestation. However, that difference was observed at 15.5 weeks of gestation in cases of preeclampsia with histologic evidence of maternal vascular malperfusion. The conclusion from the data just reviewed is that biomarkers in maternal blood predict earlier obstetrical diseases when they are defined based on placental pathology. The second major observation was that the magnitude of association between an abnormal PLGF soluble fleet ratio and the occurrence of syndromes increases in patients with placental lesions of malperfusion. Indeed, the strength of the association between the concentration of biomarkers and the occurrence of complications of pregnancy is greater when outcomes are defined by the presence of placental lesions of maternal vascular malperfusion. For example, for preeclampsia, the gray bar represents an adjusted odds ratio of 4.1 without considering any information about placental pathology. However, the odds ratio increased to 6.9 when the disease is defined by hypertension and proteinuria and the presence of maternal vascular lesions of malperfusion. The blue bar shows that the magnitude of association is weaker in the absence of such lesions. Similar observations were made for small for gestational age, preterm PROM, and preterm labor. We observed that each obstetrical syndrome had a characteristic profile of PLGF soluble fleet ratio. This graph describes the profile of the PLGF soluble fleet ratio in obstetrical disorders with placental lesions of maternal malperfusion, compared to normal pregnancies, pregnancies with preterm labor in blue, PPROM in green, late preeclampsia in red, small for gestational age in yellow, fetal death in black, and early preeclampsia in orange, had a progressively more marked difference in their profile of PLGF soluble fleet compared to that of normal pregnant women. In conclusion, when obstetrical diseases are defined by the combination of clinical signs and the presence of placental lesions of maternal vascular malperfusion, the performance of the biomarkers improve. By including placental pathology, biomarkers become informative earlier in gestation and have a stronger adjusted odds ratio for the development of each obstetrical syndrome. Obstetrical disease should be defined not only by signs and symptoms, but also by the findings of placental pathology.